morning, everyone. This work? Yes, there it is. I just had a few announcements before we begin. A few people have asked about the papal audience tickets for tomorrow. I will be picking them up this evening, and then I'll have special hospitality desk hours. I think I had them on the screen from 7:30 to 9:30, but you can reference the first Notre Dame medical ethics slide that's usually up there. It's like the home screen for the extra hours tonight. So I'll be at the desk from 7:30 to 9:30 for you to pick those up tonight, and then official hospitality desk hours start at 8 o'clock in the morning tomorrow, but I'll be there at 6 in the morning to 8 if you want to pick them up super early if you weren't able to pick them up tonight. And then Lindsay will be there at 8 a.m. to take them over for anyone who wanted to pick them up later. I did notice that there's a discrepancy between the hospitality desk hours that are listed in your packet and the hours that are listed on the handout that we have at the registration desk. So this handout, these are the correct hours, so you can use them as for your reference, and then I'll have the correct hours on that slide also. The internet is not working as of right now, as most of you may have noticed. There's a problem with the server on campus, so they're working diligently to get that fixed, but all of you know the current hour on campus, so it might be a while before we can get that fixed. Then I'll give things over to Ryan Madison, who will...
Good morning. Good. Thank you. So as Laura mentioned, my name is Ryan Madison. I'm the Associate Director of the Center for Ethics and Culture, and I want to welcome all of you to the fourth session. We have two speakers this morning, and we'll go for about 45 minutes, break out into our group sessions for about 30 minutes, and then come back for hopefully about 15 minutes of questions. So we have two speakers today, John Schirger and Luis Jimenez. And so they'll do back-to-back presentations on a roughly the same theme, and then each will speak for about 20 minutes. Dr. John Schirger practices cardiology with a specialization in advanced heart failure, and serves as an assistant professor of medicine at the Mayo Clinic in Rochester, Minnesota. He received his medical degree from Creighton University School of Medicine and his master's in philosophy from Catholic University of America. His areas of expertise include LVAD, cardiac transplantation, heart failure, and issues in the philosophy of medicine and ethics. John is the Assistant Secretary of the Catholic Medical Association. Luis Jimenez is the founder of the St. Martin de Porres Medical Center in Ocala, Florida, an organization dedicated to providing the highest level of medical care with dignity and compassion based on sound academic and ethical principles. Luis received his medical degree from the University of Florida and practices as a diagnostic radiologist. He is also a member of the Catholic Medical Association. This morning they will present a lecture entitled "The Crisis in Healthcare as a Crisis in Care," looking at healthcare through the lens of Peter Augustine Lawler and David Schindler. So please join me in welcoming John, who will speak first.
Well, thank you all. Thanks for the privilege of presenting to you, and thanks, Ryan, for a great introduction, and Carter for inviting us, and Laura Nash for all your help in organizing. And I've had the opportunity of attending this conference with a number of you for several years, and I'm humbled in your presence. I've seen the quality of the presentations, and I'm just thankful to be able to share this with you and chat with you a little bit this morning. It's a little bit maybe perhaps misleading, my talk. The title of the talk, I do utilize Peter Lawler and David Schindler briefly to give a prism to look through at some of the issues related to healthcare, in particular care in our healthcare, the notion of care in our healthcare system. I don't have, can you hear me okay? Is this working, the microphone? Thanks. I don't have any disclosures. As Ryan mentioned, most of my days are spent taking care of patients with advanced heart failure, and I do a lot in taking care of patients with artificial pumps or LVADs, primarily left ventricular assist devices. I know there's surgeons in the room. I'm not a surgeon. I'm not pretending to be a surgeon, but take care of them from a cardiac perspective. I do think philosophically from time to time I try to, and as Ryan mentioned, I have a background in philosophy from Catholic University of America, where I was very fortunate to study. Just briefly, I'd like to acknowledge members of my group at the Mayo Clinic who make my practice very gratifying and worthwhile, as well as my colleagues on the board of the CMA. So, yes, I don't think that we always talk about a crisis in healthcare, and I think that there's discussions about payment plans and delivery or provision of healthcare, the relationship of big government to private healthcare, or I like to think of it more in terms, as I'm sure many of you do, in terms of subsidiarity and solidarity. Is healthcare crisis related to a crisis in the family or a crisis in demographics? Certainly, some people have already discussed here the issue of conscience rights, and all of these are clearly crises or aspects of the crisis in healthcare. I guess I'd like to ask somewhat of a bigger question: is there a crisis in care? And that relates to how we look at a human being, the dignity of the human being, and how we define human nature. And within the medical realm, what's the relationship between us? Many of us are physicians, and our patients who are vulnerable and many times frightened. Do we look at that in terms of a covenant relationship, as Dr. Pellegrino, who's spoken here, would advocate, or do we look at it in terms of a provider-client model, which is, as you all know, in vogue? And another question I'd like to ask, or a theme that I'd like to run through this discussion, is: can a notion of care in the setting of very significant suffering in patients who are very ill, an adequate notion of care truly be sustained absent a world view that's open to the transcendent? This is an overview, and I'll just quickly go through this. I'll touch on most of these points later. John Paul II, in his document on suffering, discusses at one point the intimidating nature of suffering. So we'll discuss that a little bit, and we'll talk about what it means to talk about a crisis in healthcare as a crisis in care. We'll talk a little bit about Peter Augustine Lawler's notion of caregivers as non-utilitarian or non-productive carers. And I had the privilege recently of, and I'm sure some of you know him, and this was the first time I'd had the privilege of meeting him. Dr. Hurlbut spoke at Mayo Medical Grand Rounds last week and just gave a tremendous talk on medical ethics needing to be within a framework of a worldview open to the transcendent, and he kindly let me use some of his ideas. David Schindler, who some of you probably know, is the Dean Emeritus of the John Paul II Institute in Washington, D.C., and I'll use his notion of the giftedness of creation to look a little bit at how we might look at our patients. I'll then give an overview of what I do, taking care of LVAD patients who are very, very sick patients oftentimes. And I'll present some cases that I hope to illustrate some of these concepts and then transition to the role of religious institutions in healthcare before turning it over to my good friend, Dr. Jimenez. So briefly, the intimidating nature of suffering. John Paul II talks about this, and I didn't put references here, and if anybody wants references, I'm happy to send them to you and so forth, but discusses the intimidating nature of suffering, and interestingly, he speaks about the intimidating nature of that to family members, to loved ones, to caregivers, to physicians. You know, I'm sure many of us have had that experience. My father died a couple of years ago, and he was very, very ill. And I can tell you that oftentimes the last thing I wanted to do was go to the hospital. It's intimidating visiting your loved ones. It's frightening seeing them suffer. It's frightening seeing that loss of control. And you wonder sometimes how those you know, without, let's be simple here, without a sense of hope in the afterlife, without a sense of transcendent meaning, can deal with extreme suffering. As I mentioned, Dr. Hurlbut in his medical grand rounds at Mayo last week, Dr. Hurlbut being a former member of the President's Council on Bioethics, as I know other members of the audience here have participated in that. He discussed the importance again of remembering this covenant relationship we have with our patients, remembering always how vulnerable they are. But the thing that, you know, I told him, we've had very good medical ethics talks at Mayo before, but I hadn't heard, and it's not new to this audience, but it may have been new to the audience last week. I hadn't heard a full-blown metaphysics presented at Mayo Clinic Grand Rounds, which of course then entails an appropriate anthropology, a teleology of human nature, and one that's open to a notion of a transcendent being. I'd like to just spend a couple of minutes on evolutionary theory. I think there's many aspects of naturalism or materialism or scientism that are used to suggest or argue against the notion of a transcendent being or teleology in nature and so forth. I guess the one I come across the most, having a background in biological sciences, is evolutionary theory, and you're all familiar with the notion of chance and selection, imperfections, beings, and chance mutations with perhaps imperfections being selected. There's concept of waste and suffering within evolutionary theory, and you know, evolutionary biologists would argue that there's no end or determinism to the process, only survival. I think the most radical of evolutionary biologists in my mind is Stephen Jay Gould, who actually has a compelling personal story. He suffered with a very difficult disease and suffered courageously. But he views natural history as radically contingent. He uses the analogy of a film. If evolution was a movie and you played it 1 billion times, it would turn out differently each and every single time. And in that scenario, of course, there's nothing suggestive of a directionality. There's nothing suggestive that we as human beings would have come about. There's nothing about us that's privileged or special. And that, you know, you all know that has consequences for ethics and obviously for medical ethics. He doesn't feel that we can read any sort of direction, and certainly not any sort of providence off of nature, if you will. I don't think that's the case, and I think evolutionary theory can be read through the prism of St. Thomas. He as people here can articulate better than I mean, for St. Thomas, divine causality and natural causality don't compete. They concur. They work together. It's a mysterious process. But most importantly, from the standpoint of evolutionary theory, chance isn't a problem for providence. Chance is subsumed along with more deterministic causes under divine providence, and neither is suffering ultimately a problem when you go through several arguments. But there have been biologists like Simon Conway Morris from the UK who have argued for the directionality in evolution, and certainly Thomistic philosophers like Jacques Maritain and Charles de Connick, who was the teacher of a very distinguished Notre Dame professor, Ralph McInerney, have argued eloquently about space, or evolutionary space, which allows for non-living, living, vegetative, animal, and ultimately rational beings. So I think there's arguments that can be made, and this isn't the place to make them in detail, but in the end, I think we can say with Pope Benedict that we're not a meaningless product of evolution, but each of us is, or at least reasonable natural thought would allow us to make a statement like this, that each of us is the result of a thought of God, a willed, loved, and necessary being. So now transitioning a little bit to Peter Lawler, he also argues about the compatibility. Well, he argues the inconsistencies of evolutionary theory, and argues for a common human nature based on biology and common human need. In some ways, I find his arguments similar to Alistair McIntyre's, in that as dependent rational animals, we're needy, we're vulnerable, and we need to work together to fulfill our human natures in taking care of ourselves. He argues that the current conception of dignity is based on productivity, a form of utilitarianism ultimately, and autonomy, which he sees as oriented towards a free existence unlimited by bodily constraints, a form of transhumanism, which it doesn't take much reflection on to realize that this is a futile project. And he argues that our experience rather shows us that dignity is found in living in the truth, serving the truth, and in knowing and loving others, and that these characteristics are given to us as gifts in nature, allowing us by implication to be gifts to each other in our service and responsibility towards each other. With respect to caregiving, he distinguishes this from productivity or productive means of employment, which by definition would generate money, or the means for generating money. And caregiving, rather, is something that's given in loving solicitude for those in need. He notes, however, that more of our caregiving, and you can just think in terms of nursing homes, long-term care facilities, our changing demographic, and so forth, that more of our caregiving is being done for profit. And he notes that often the workers who do this caregiving are underpaid, and unfortunately, and I've seen this and many of you have, may attend to the minimum requirements of daily existence, just helping their patients or elderly or disabled population get by. He argues for the need to support programs that allow family and friends to do what they want to do, which is care for their loved ones. So basically, he argues in some way for a governmental or higher level support for more local programs. He does, again, however, make the point that we're all a gift to each other and we fulfill our human nature in serving as a gift to each other. And David Schindler brings this out nicely in one essay. He distinguishes the care, and it's a little bit difficult to articulate, but he distinguishes the care provided by a paid caregiver as opposed to the care provided by someone like Mother Teresa. Though the tasks they may perform may be very similar, and indeed oftentimes the exact things that are done are the same, although he acknowledges that a motivated, loving caregiver may actually do more in terms of quantity of care. The main difference is, however, more elusive, a gentleness in the sense of caring, a smile. And I think this is important. And it's a simple thing, but it's worth dwelling on. Understanding that the person you're caring for is a gift and that their being there for you to care for them is a gift that allows yourself to be fulfilled. Again, simple concepts, but anybody who's experienced someone being cared for in the hospital, in a nursing home, where the caregiver is going through the motions, as opposed to someone who's doing it out of joy and a sense of that person being a gift to them, it's a huge difference. And I think many of us have experienced that. So very briefly, I'm going to make a transition to what I do in daily practice and then talk about a couple of cases. And so this is a sort of a big split in the talk. But without going into a lot of detail, the burden of heart failure is increasing in the Western world significantly. And there's a small but significant population of people with heart failure who proceed to advanced heart failure requiring consideration for transplant or mechanical assist support. Mechanical assist support is often in terms of something called LVAD, or left ventricular assist device. There's other forms of mechanical assist, total artificial hearts and so forth, but perhaps the most common is LVAD. The older pumps were very large and cumbersome pieces of equipment that pumped with principles of fluid dynamics and wore out within a year and a half. And at that point, patients would require pump exchange, transplant, or die. And each pump exchange brought more and more risks and comorbidities. The newer generations of LVADs are continuous flow pumps. This is one type that works with a rotor, and they are much more durable. In both cases, the pump is inserted into the apex of the left ventricle, or the part of the heart that pumps blood to the body, and actually the blood is diverted to the ascending aorta. The heart contributes still to flow, but much of the blood is pumped out around this way, and it provides a lot of support. These have been used as bridges to transplant. And these are terms that are used with regularity as destination therapy. That's if someone's not a transplant candidate, then they're considered destination therapy candidates. As bridge to candidacy, there are people who aren't currently transplant candidates but can become transplant candidates, and in very rare cases as bridge to recovery. This is what the pump would look like on a model. There's an internal-external interface which causes some lifestyle issues, and this is what the pump might look like on an X-ray. This is an alternative pump. I don't know how well it shows up. There's a lot of glare, but it's a relatively big piece of equipment. This gentleman obviously gave permission to have his picture taken. This is several years ago, and you can see that he can walk around, and these patients are discharged and walk amongst us without our knowing. Often the battery packs and so forth are much smaller today than this. These pumps have been shown to increase longevity, increase lifespan in advanced heart failure. They've been shown to be successful as bridge to transplant strategy. They improve exercise capacity and improve quality of life. There are, however, complications. These are left ventricular assist support devices. They don't support the right heart directly. The blood comes back to the right heart, and if the right heart isn't functioning well, people can have kidney failure, liver failure of varying degrees. Infection is always a concern, as is the pump clotting, requiring pump exchange, stroke, and multi-organ failure. And this is a separate talk in itself, but I'll just touch on it. Discontinuation of the pump provides for some interesting thought, and I think it's worth reflecting on how these pumps are different than other forms of mechanical support. This is continuous support, and as such, it's different than dialysis or than a defibrillator, for example. A person is mobile with this. They walk around. And that can be done in some cases with a respirator, but it's much more difficult and less common. Oftentimes, the pump doesn't provide much of a burden of care, although if it's not functioning well, it does provide a burden of care, and it's worth asking what is pump malfunction in certain situations. So let me just very briefly run through a couple of cases, and then I'll turn this over to Louis. These are not necessarily people that I've taken care of, although they may be, and it's a compilation. They're somewhat hypothetical cases, but they're compilations of real-world situations. So we have a 74-year-old gentleman with valve-related heart disease who's had a mechanical mitral valve placed, which means he requires blood thinners. He progressed to end-stage heart failure and had an LVAD placed. He was otherwise doing well and had no significant medical issues, and his pump was functioning appropriately. He tripped and fell and had an intracerebral bleed, but recovered from that, relatively speaking. He had, the bleed was into his frontal lobes, and he would have intermittent times of inappropriateness. And he was deemed to have a lack of insight and a lack of self-caring capacity, but he could walk around and talk to you, and sometimes could be quite pleasant. His blood thinner was restarted with the blessings of our colleagues in neurology and neurosurgery, and his heart pump continued to function appropriately. His wife had scleroderma, a rheumatologic disease, and was unable to help adequately with his pump care. And there wasn't an adequate disposition for him. He was living in the hospital, and we approached long-term care facilities, and he wasn't accepted due to concern for caring for the pump. One day he developed an episode of more extreme agitation, and this resulted in his being sedated and a family care discussion. And that evening his pump was turned off, and he died in 20 minutes. Second case is a 76-year-old gentleman who had had an LVAD for 6 years. He had chronic right heart failure, kidney dysfunction, and hepatic dysfunction. He'd had a recent pneumonia, and had progression of his right heart failure and organ dysfunction. He began to develop delirium, and we discussed the possibility of adding medicines through an intravenous catheter to help his right heart, because the problem was his right heart. He would have had to have a separate pump that he would have had on his arm or in his neck through a line. The family decided, and I think very reasonably, not to escalate his care. And he had progression of all of his disease processes, and the question became, at what point do you turn off the pump? The family decided they'd like to have his defibrillator turned off and that he not receive further antibiotics or medicines that support the right side of his heart. They gathered together, they spoke with him, they prayed, and over 2 days he developed, progressive respiratory failure and was sedated, and when his respirations became very shallow, his LVAD was discontinued and he died. I should mention, if an LVAD isn't discontinued and a person stops breathing and they have compromised flow from their right heart, the pump will start alarming, and it's a very noisy alarm, and it's obviously distressing to a patient if they're alive, or a family if the patient is not alive. Quickly, third case, 54-year-old gentleman who had long-standing heart failure due not to blockages of his coronary arteries, but to idiopathic non-ischemic cardiomyopathy. He didn't have a lot of other illnesses, but had been hospitalized multiple times and was actually on inotropic therapy for about a year. He was actually deferred or turned down for transplant because of lack of psychosocial support. And concerns were raised regarding this due to his, about psychosocial support. Concerns were raised regarding LVAD candidacy. The social support issues were partially addressed, not fully, but through a lot of discussion, those were partially addressed. The patient received an LVAD and is doing well. And I think, it's worth thinking about how were each of these patients cared for in the context of the principles of subsidiarity and solidarity. Case 1, the gentleman who slipped and fell, had the intracerebral bleed recovered, was inappropriate, and had the pump turned off. I guess I'd ask the question, was there a lack of solidarity? Is there a reason we couldn't ultimately, as a society, find our way to have a nursing home that might accept a patient like that? He would have otherwise, under all circumstances, just gone to a nursing home. Case 2, I'll let everybody think about it, but in my mind that was a very appropriate discontinuation of an LVAD. Case 3, I thought, was a nice example of family and community and the healthcare profession rallying together to support a patient and get him a solution. So I'd like to transition to Lewis's part of the talk here real quick, but just really quickly to say, while we need to continue to make sound arguments in medical ethics, continue to work in the legal arena and advocacy for patients and disabled and the elderly, we need to keep looking at improved methods of payment, delivery, and efficiency of healthcare. And we need to support all efforts at basing care on the intrinsic dignity of each patient. I think that this notion of care that I brought up and the sort of the intangible components of that, at least in my experience, I've found that intangible component comes forward, is unveiled, often in the setting of religious people caring for patients. And just to briefly transition here, the institution I work at, that I'm privileged to work at, was founded by the Sisters of St. Francis in collaboration with the Mayo brothers and Dr. William Mayo, their father, in the late 1800s, early 1900s, after a tornado swept through Rochester, Minnesota. And for many years, and to some extent today, that I think that religious ethos permeates that institution, although it's no longer a Catholic hospital. On the right is, I think it's Sister Alfred, who was one of the Mayo brothers' scrub nurses. I couldn't get a picture, but many of you may know the Religious Sisters of Mercy from Alma, Michigan. They also have a clinic in Jackson, Minnesota. This is their foundress, and they take wonderful care of patients. It's really a privilege to see them care for patients, and I've seen them do that. And their founder said, her sisters went forth to nurse the sick in their homes and in the public hospitals and to perform various corporal and spiritual works of mercy. And I think there's a need, and more than a role, but a real crying need for a religious element to be reinstituted in healthcare. I've talked too long. I think it's really more important, actually, that you hear what my good friend Dr. Jimenez is doing with his new medical center, St. Martin de Porres, that I'm privileged to serve on the board of as well. How do I push escape here, or, all right, okay. Watch Lewis.
Again, my name is Dr. Luis Jimenez, and I'm from Ocala, Florida. We're located about an hour and 15 minutes north of Orlando and about 40 minutes south of Gainesville, which is where the University of Florida is located. I'd like to thank again Carter and Laura and all those who have invited me to speak here today. This is my first meeting here, so I'm honored to be here. Up till now, I've heard some great lectures and discussions on biomedical issues and on legal issues, and I think it's incredibly important that we be aware of those issues, that we discuss those issues, that we support proper legislation that promotes Catholic and ethical health care. I guess the focus of my talk is how do we implement these discussions, this effective Catholic health care and ethical care in a way that is lasting. And I think it's vitally important that we work on establishing or reestablishing Catholic health care in this country in a manner that is consistent with the teachings of the Catholic Church. I also think it's very important that we network, not necessarily that we form one Catholic healthcare system, but that we form Catholic healthcare facilities throughout the country that will be able to network with each other, because I think through networking we'll have much more influence and power, and I think we will be less vulnerable to being dismantled. To give you an example, in the Diocese of Orlando, where I live, there's not one Catholic hospital, and it's a fairly large geographic diocese. It extends from south of Orlando all the way up to Ocala, like I said, an hour and 15 minutes north, and it extends to the east coast, to the Atlantic coast of Florida. So not one Catholic hospital exists right now. So to move on, St. Martin de Porres Medical Center is the medical practice that we are establishing. The mission of our practice is to provide the highest level of medical care with dignity and compassion based on sound academic and ethical principles. Okay. Our plan is to establish a faith-based multi-specialty medical center that will provide all needed outpatient services and care on one campus. And I use faith-based because we are in the Bible Belt, and interestingly enough, there's strong support from non-Catholics. And I think it's very important that from a Catholic healthcare facility that we evangelize through our practice of medicine, that we include others who are not non-Catholic into our practice. However, we always practice consistent with the teachings of the Church. So in our Articles of Incorporation, we specifically have stated, and any employee would be well aware of this, that we will provide health care services to all persons born and unborn in a manner consistent with the teachings of the Roman Catholic Church and without regard to race, color, religion, gender, national origin, or financial means. The medical center is being established as a 501c3 not-for-profit organization. There's a variety of reasons. I won't go into all the reasons for this corporate structure. One of the main reasons that I think it is important is to preserve the mission of the practice. I've seen many practices of goodwill amongst Catholic physicians and non-Catholic physicians that unfortunately fall apart due to what I believe are frivolous issues. There's everything from financial issues to ego issues to just very simple disagreements in belief that people can't get along. And the Mayo Clinic on a secular level is a 501c3. And what I found very interesting about the Mayo Clinic is that you can have some obviously great physicians who can make a lot more money in private practice, and they have a great distinction in their field, yet as individuals within the Mayo Clinic, they're a little part of the Mayo Clinic. And that's important. It's not that they're insignificant, but again, the mission is what needs to be preserved. So going on, our facility will accept private insurance, Medicare, Medicaid, as well as other developing reimbursement models. We're working on the possibility, if it develops, of partnering with a free clinic in our diocese that I think may develop in the town of Ocala. Okay, some services offered at our facility as we develop. Of course, primary care will be the cornerstone and base of the practice. We'll quickly move into subspecialty medicine. We have a predominantly elderly population in Ocala, although there is a younger population that is growing, so we clearly can support virtually every subspecialty area in medicine. We'd like to provide outpatient procedures, laboratory services, diagnostic imaging and testing, a pharmacy, and all ancillary services such as physical therapy, wellness care, dental, vision, mental health, and any needs that will arise in our community. So looking forward, I think the basis is to start as an outpatient medical center, but I think we do need to move towards inpatient type services. Some examples for our community are assisted living facilities, which right now most of them are out of pocket for profit type of situations. So our philosophy will be a little bit different, and most of the assisted living facilities drop patients once they no longer can be cared for in that type of setting. So I believe that we also need to provide for skilled nursing, because patients will transition, many of them, from an assisted living to a skilled nursing facility as they have medical illnesses such as strokes, where they can't be cared for at an ALF. A very strong, I think, or important part of moving into inpatient type services is a Catholic hospice. Again, we're in an elderly community. A Catholic hospice, I believe, is really essential. I believe that we need to support all the legislation on end-of-life issues. We talk about euthanasia, physician-assisted suicide, terminal sedation, all the different terms that come up. And we support all the legislation, obviously, to be consistent with our faith. But the reality, at least in our community, is that hospices are highly variable. You really cannot regulate what goes on in each room. And in a proactive sense, if we have a Catholic hospital, our hospice, a Catholic hospice, what we can do is know that we're practicing a certain way. And to me, that is the effective way of really giving compassionate care with dignity to patients at the end of life. In addition, I'm personally a fan of academic medicine, so I'm making some efforts to establish collaborative and clinical research associations and partnerships with academic institutions. I think academic centers like the Mayo Clinic have just incredible resources. However, the ethics at most institutions, I was trained at the University of Florida, and we had some really, really great divisions. But when you come to the ethical issues, technology moves fast, and physicians tend to follow the technology quickly, but they don't really think about the implications of that technology. And I think it's important to bring in Catholic ethics and morals within that academic research so that we can provide really the highest level of medical care with the combination of the ethics and dignity that's necessary. So this image is, we were very fortunate that in November of 2014, we purchased our first facility. We have 2 double buildings. This is one of the double buildings, and this is the second one. And we have 18,000 square foot of space that we own. And in addition, we own about 9 acres of land, and it's not just barren land. It's actually has multiple ready-to-build pads. So we have an infrastructure that is there so that you can build. Every pad actually has underground utilities, fiber optics, water and sewer, everything ready to build additional buildings, so that our final build out on the 9 acres can approach 75 to 80,000 square foot of space. Wanted to give you a little background on St. Martin de Porres in case you're not familiar with him. He was lived from 1579 to 1639, and the appeal of St. Martin de Porres is universal. He's called the Apostle of Charity, patron of social justice, father of the sick and poor, helper in hopeless cases, and is a powerful intercessor and example to those in need and those in the medical profession. St. Martin was born in great poverty. His mother was a Peruvian woman of African descent, and his father was a white Spanish nobleman who traveled colonizing Latin America. So he wasn't present all of the time, but one thing that he did do is that at the age of 12, he facilitated that St. Martin could apprentice under a well-known and respected surgeon barber in Lima, Peru. And as many of you know the history of medicine, a surgeon barber at that time was literally a doctor and a surgeon and a barber and a pharmacist, and everything rolled into one. So he learned a lot of skills, and he really took on his duties passionately and diligently, because it is told that he could see into the soul of the individual. So even at a young age, being a mulatto, which is the lowest class of society, he saw the dignity in everybody, obviously in himself, but most of all in those around him. And even though he was very poor, the stories are that his mother would give him a little bit of amount of money to go and buy food, and he would always find people that were less well off than him, and he would end up giving the money away and not coming back with the food, and he would get in trouble for it. But it really showed the the level of charity and humility that he lived with. He was extremely diligent. He worked extremely hard. He slept very little. So he applied himself to the study of medicine at the time. And within a year or two, he was actually practicing as, at the level of his mentor. And people were coming to see him at the age of about 14 or 15 years, which is, I think, pretty remarkable. He truly was a natural healer, and I think his holiness allowed God to work through him. And he used his physical means, sacrifice, and his love of God and fellow man to practice medicine. So this is a little wordy, so I'm just going to go a brief overview on some of this. So at 15 years of age, Martin entered the Dominican monastery of the Holy Rosary and was admitted as a tertiary helper. Of course, he already knew medicine as a background, so he automatically took over the infirmary duties there. He always wanted to perform the most lowly tasks, cleaning toilets. You frequently see him with a broom, as you see with the picture there, because he was cleaning constantly. And he was doing all of the tasks that nobody wanted to do. And over time, more and more tasks were placed on him in the order. And it was over time also observed that he was performing the tasks of more than one person, because it was beyond just the physical human capability of the individual, what he did. He literally took care of all of the sick. He took care of sick people in the streets. He fed 200 people each day. He took care of the animals. So veterinarians also like St. Martin de Porres a lot because he cared for animals. And God gave him the gift of being able to cure the sick using natural and supernatural needs. And in his sense of humility, he always treated patients with conventional means. So if a miracle occurred, he never would call it a miracle per se. He knew it was a miracle inside, but he never wanted to draw attention that God was using him to perform the miracles. So he used conventional medicine and then prayed over the patients and allowed God to do the healing. So just a quote, his industry was unflagging, his obedience and humility most sincere, his spirit of penance extraordinary, and his charity knew no bounds. As I said, his humility sought the lowest places in the community, and it wasn't until 9 years later that he was actually asked to be a full-fledged brother. He actually kind of resisted being a brother. He never felt worthy of it and never really wanted to move into a position where he got any recognition for what he did. Okay. Again, St. Martin possessed numerous outstanding virtues, and many of these virtues we don't see today. They're virtues, I think, that are essential in medicine, specifically charity and humility. And somehow through the training process and the practice of medicine, at least humility, I think, falls by the wayside very early on. And I think as physicians, we really need to remind ourselves to be humble, and that we're taking care of someone in front of us, and that the care that we provide is not about us, but it's about helping the patient have a better life. Okay. So the purpose of St. Martin de Porres Medical Center, named in honor of this great man, is to reinvigorate the practice of medicine with these essential Christian values. And then Holy Father Benedict XVI, on the 50th anniversary of the canonization of St. Martin, prayed to St. Martin that he would intercede for the work of the new evangelization, so that holiness would flourish in the church. And I would say within medicine too. So again, the cornerstone of this is charity and humility. I put up a slide. We do have a website that's being built. It's St. Martin de Porres Medical Center.com. You have to spell out all the letters. But I wanted to move on to one case discussion. And this is an example of patient care. One patient that was dealt with in two very different ways. It's an 82-year-old who presented with abnormally elevated LFTs and increasing bilirubin levels. He developed visible jaundice within 3 weeks and underwent an MRI of the abdomen. So I'm a radiologist. Of course, I like to show radiology images. And the two pointing arrows show a small enhancing hilar lesion right at the junction of the right and left lobe of the liver. If I can use this. So it's this little area here. And the left lobe of the liver, you see these flow voids, which here are bright on the T2 sequence. And that is significant intrahepatic biliary dilatation throughout the left lobe of the liver, with sparing of the right lobe of the liver. So these MR findings are highly concerning for a small cholangiocarcinoma. The patient, after his MRI, went to the gastroenterologist, and the gastroenterologist told him that it looks like you have a cholangiocarcinoma, which is an aggressive tumor, of course. There is really nothing that can be done for you, and you'll likely die within about 9 months. And what we will plan is an elective ERCP and stenting to alleviate the obstruction. So the same patient decided to undergo evaluation at the Mayo Clinic in Rochester, and he underwent an ERCP with biopsy brushings and the placement of 2 biliary stents. At the same time, he had a surgical consultation with a pretty renowned hepatobiliary surgeon who said that based on the imaging and ERCP findings, he was a surgical candidate. So these are some images of the ERCP. And you can see that there's some irregular narrowing here. And they had to pass guide wires and a balloon, and here you actually see they had to balloon up, and here's what we call a waist, kind of a waist, the irregular narrowing of a stricture that had to be ballooned in order to actually put in the stents. And it was hilar, so it had to occur on the right side as well. So it's classified as a Klatskin's type tumor. And here I have on the left-hand side, we have an MRI, and the MRI on the left-hand side is the one I showed you earlier. So this is when he first presented. The MRI is on the right side. This is about 5 to 6 weeks later after stent placement. And the bilirubin initially was over 25. After placing stents, it was under 2. There's still a little lesion here, which on the first one they gave gadolinium, which allowed enhancement, and that's why it was white, but you see a little void where the stent is. But notably what you see is the biliary dilatation has decreased, so the stents were obviously functioning well. And this is the a little depiction of the left lobe of the liver, the medial and lateral segments of the left lobe of the liver. So the patient, after 5 to 6 weeks, returned to the Mayo Clinic, and he underwent initial laparoscopic surgical evaluation revealing no visible intra-abdominal metastatic disease. The surgeon obviously was pleased and immediately converted to the open surgical approach for definitive surgical resection. So this 82-year-old patient had a complete left hepatic lobectomy with hepaticojejunostomy, cholecystectomy, hilar lymph node dissection. Frozen sections revealed clear margins with no lymph node involvement, and actually the final pathology confirmed it. And in the end, the final pathology revealed that the tumor was only about 1.5 centimeters in size, very small, that the stricture was actually a desmoplastic reaction, so it was not even a malignant stricture. which was all, of course, good news. The patient tolerated the procedure extremely well, with virtually no blood loss in this surgery, which is a very significant surgery to remove the entire left lobe of the liver. He had complete resection of the neoplasm and is currently making great strides to resume his normal level of activity. So the hepatobiliary surgeon, his name's Dr. Nagorny at the Mayo Clinic. I point him out. I don't know his religious belief, but what I do know is he treated his patient with compassion and offered care with dignity and hope. And as physicians, we're all called to care for our patients with dignity, charity, humility, and hope. And I have to say, even with I happened to speak with Dr. Nagorny, and he's reserved. He's well-renowned, so he's careful in what he says. But what I did see is a great sense of satisfaction that the right thing was done. He never had a reservation about doing this procedure on an 82-year-old, but he had a little bit of concern because of the age, but not significantly. He felt he could do it successfully. And after everything was done, it was very clear that he was very pleased that this was done. So that concludes my part of the talk. Thank you.
Before Ryan comes up here, I just want to say the patient, and that was Dr. Jimenez's father.
Well, thank you very much, John and Louis. So there's a little bit of a change in the plan. So we're just going to break into our groups for 30 minutes, and then go from there directly to the break, to the coffee break, and we can continue discussion over coffee if you have questions and want to ask John or Louis. We'll do that during the coffee break. Okay. Thanks.